Good evening, everyone. It is 7 o'clock. We are going to get started. Welcome to Wednesday Wellness, a free live educational series presented by Trinity Health Medical Group. Thank you very much for joining us this evening. Before we turn it over to tonight's presenter, we would like to provide a few reminders. This presentation is being recorded, and you will receive a link to that recording within the next few days. If you have questions, please utilize the Q&A chat, which can be found near the bottom of your screen. Questions will be read after the presentation and then answered by our presenter. And without further ado, I would like to introduce Dr. Joshua Greenberg, the lead vascular surgeon with Trinity Health Medical Group. Welcome, Dr. Greenberg, and thank you very much for being here.
Hi, good evening. I'm Josh Greenberg. I'm one of the vascular surgeons, the lead physician at Trinity Health. We also provide care and coverage for University of Michigan West. Thanks for joining me this evening and taking time out of your days. I hope that what you learned tonight, in lieu of watching the news or some sort of the television show, is helpful to you in meeting, improving your health overall, living longer, hopefully, and most importantly, living a meaningful quality of life. So I'd like to get started here on my topic, which is vascular health. A little bit about me. This is actually my 10th year in West Michigan from California. So today I'm much more familiar with the weather out here today than I am what we saw about a month ago. So we're happy to see that. Special interests of mine include incisionless complex aortic aneurysm repair, peripheral arterial disease, which we're going to touch on quite a bit during this talk, which includes limb salvage, and a particular subspecialty of mine is an entity called thoracic outlet syndrome, which we're not going to be talking about today, but that's something that I have some expertise in. Today, or tonight rather, we're going to talk about an overview of what vascular specialists are and who populates that space, vascular anatomy a little bit, maybe some physiology. Hopefully we won't put you to sleep from that. Cardiovascular risk factors and risk management. Overview of 3 vascular conditions that I'm going to touch on, including peripheral arterial disease, or PAD as you may have heard it referred to, carotid artery disease, and abdominal aortic aneurysm. So in the vascular space, as we would call it, essentially the area of medicine that involves the circulation, you'll find providers called labeled vascular surgery, like myself, for example. Surgeons that are trained in treating essentially the pipes in the body, but through both surgery, as I'll get into, as well as minimally invasive means and medical means as well, non-invasive. Cardiologists work in the space as well. There are far more cardiologists in the United States than vascular surgeons, and they certainly occupy some of the space. Interventional radiologists, many of you may not have ever come across or know what an interventional radiologist is, but it's a radiologist that also does invasive procedures, and they were very much involved in the origins of vascular treatment invasively when it involved catheters. And then vascular medicine. That's a subspecialty of internal medicine that just specializes on in the medical management of blood vessel diseases. Surgery is only part of the story of vascular surgery. Again, that's my specialty. A vascular surgeon does far more than surgery. Vascular surgeons manage veins and arteries throughout the body, except the brain and the heart. The vascular surgeons are able to do really every kind of vascular procedure or use non-invasive treatments. We, of course, build relationships with patients. That may seem obvious since we're doctors, and don't doctors always do that? Well, we don't just do invasive procedures. There are many specialists who kind of do the procedures but don't do long-term follow-up of them. And our expertise is doing the procedures but also having long-term relationships with patients. So what is the vascular system? Well, the vascular system is made up of vessels that carry your blood throughout your body. You may see them, such as the veins on your hand. I don't know how well you can see that, but arteries carry oxygen, rich blood away from your heart. Veins carry oxygen, poor blood back to your heart. And the blood leaves the left side of the heart, is pumped to the rest of your body, and then it returns. The main artery from your heart is called the aorta. That's sort of like I call it the water main. As blood travels throughout your body, it enters the smaller and smaller blood vessels, reaching every cell, dropping off oxygen and nutrients, and then picking up waste products. It then enters the veins and makes a long return trip back towards the heart, and repeats that all over again. So people sometimes use the terms vein and artery interchangeably, but they're not the same. So I was in my clinic today, and to no one's fault necessarily, but I probably had at least half patients referring to the arteries as veins, which, understandably, they're not vascular specialists and not in the field, but it's important that there is a difference between the two. The arteries deliver the oxygen and the veins return. And there's implications for that, because generally conditions that involve the arteries are far more dangerous in terms of loss of limb or life or other structures than veins. That's not to say there aren't severe vein issues such as pulmonary embolism or deep DVT or deep vein thrombosis. Here's some pictures of arteries and veins. You can see arteries are thicker. They have a very thick outer layer, which generally distinguishes them. They're very rubbery. Veins have valves, so the valves prevent the blood when working normally, for example, in the legs, from backing up back into the legs when you stand up. Otherwise, legs could get huge and so forth. And when those are abnormal, conditions can arise from that. This is just a rudimentary picture of the circulation, as you can see, obviously with the heart at the center. I don't know how well or if you can see my pointer, but if you can see my pointer, the central artery in the middle is the aorta, which then splits off to the iliac arteries in the pelvic area, going down to give off the blood vessels down to both legs. Not a lot of redundancy in the circulation on the artery side. A lot of redundancy on the vein side. That's why I'm kind of finicky about when people just say, "Oh, you're here. I'm here to have my veins checked." Well, there's almost no arteries that you can actually dispose of that are redundant. I mean, there may be one or two, but there's many, many, many veins that you could dispose of, and we do dispose of when we use them as spare parts in surgery and that kind of stuff, such as in bypasses. So disease processes that can involve the circulation, coronary artery disease, which I don't treat because I treat, as I was mentioned, the circulation that's outside the brain or the heart as a vascular specialist. But the coronary arteries are treated by cardiologists and heart surgeons, but they're subject to being blocked off. The peripheral arteries, or PAD, we're going to get more into it, involves the arteries outside the heart and the brain. Cerebrovascular disease is also a subset of peripheral vascular disease or peripheral artery disease, and that involves the circulation to the brain. And then venous disease. These are just some examples. We're not going to touch much because of time going into that a lot, but that's certainly an area that we treat as well. So here's an example of the heart. You can see the coronary arteries develop plaque and can get blocked off. The arteries to the legs get blocked off and can have pain when you exert yourself, and we'll get into that. The arteries to the brain can get blocked off, such as the carotid arteries, and that can lead to stroke. And then finally, as an example, clot can form in the veins in the legs, and when that clot forms, it could break off and potentially go to the lungs, which is called a pulmonary embolism. Medical emergencies that you might have heard of involving the circulation. And, again, this is sort of what I just referred to. Myocardial infarction is the medical term for when the coronary arteries clot off, and clot can form and block off, and that can cause a heart attack. Stroke, as we talked about with the arteries to the brain. Acute limb ischemia is when blockages can occur in the legs, which can lead to a threat to the legs where you can actually be at risk of losing your legs. And as I just talked about, DVT and pulmonary embolism, when clot forms in the vein in the legs, or clot can travel to the lungs. So what are some of the signs of possible cardiovascular disease? Just things that can be observed. Obesity is a common sign and marker for cardiovascular disease. Generally, we're looking at a waist size of at least 40 inches in men and 35 inches for women. This isn't an absolute, but this is kind of what's fallen out of studies on cardiovascular disease. Colder extremities. Now, of course, not everybody with a cold extremity has peripheral vascular disease, but it's certainly it's certainly a sign. And the same thing goes along with hair loss or erectile dysfunction. And none of those things definitively mean you have vascular disease, but they are certainly can be signs associated with it. Non-healing leg sores and shortness of breath with mild exertion, for example, can be a sign of cardiovascular disease, or can just be a sign that it's been a long winter and you haven't been able to exercise. But it's something to think about. So risk factors that you may not always see on the surface that are at present. Modifiable risk factors include age. Yes, we can't modify that yet. Gender, genetics, and race. These are all things that you're kind of born with. You can't generally escape in terms of your constitution, at least, and you can't modify. The ones that we focus on, however, are screen right, which are the modifiable ones. These are things that are the big ones. This would be kind of like the big six here. Include smoking, which we're going to really touch on. Lipids, so cholesterol and triglyceride and fat elevation in the blood pressure, diabetes. Now, not every form of diabetes, there are some real genetic or inherited forms that you just can't modify, but you can control if you, let's say, are born or you have your pancreas removed, which releases insulin, and you choose not to take your insulin. Well, that's a modifiable risk factor. Obesity is generally thought to be modifiable to some extent, and activity. Smoking, I could spend all day talking about smoking. I try not to in my clinic all day because I realize patients would probably never come see me again. But the reality is smoking plays a big role in the progression of atherosclerosis in the aorta, coronary arteries, and arteries in the legs. Smoking makes and contributes to fatty deposits and makes fatty deposits more likely to form and accelerates the growth of plaque. And so, I was thinking about this before my talk. I won't get too far into this, but it is amazing that cigarettes can still be sold. And frankly, there's markets in the world where they're being sold at more than ever. So it's an extremely dangerous substance. Obesity is a disorder that involves having too much body fat. I think we know that. Usually a body mass index or a BMI of 30 or greater signifies obesity. Over 25 is generally considered overweight. And that's a tough one to avoid, but it takes work really to be below 25. It increases the risk of serious health problems such as cardiovascular disease. Obesity often results from taking in more calories than are burned by exercise and typical daily activities. Again, we know there's multiple things at play here. I'm not trying to say that everyone who's obese eats too much and doesn't exercise, but as a rule, those are big contributing factors. It's important to note that if you look at from 1999 to 2000, the year 1999 to 2000, between the period from 2017 to 2020, there was basically a 6 or 7% increase in obesity in the US, and everything just tracks up from there. Obesity has really become quite an epidemic. So how to reduce cardiovascular risk, sort of from a medical perspective? Well, first of all, there's many online reputable calculators. You could go to the American Heart Association website, some of the societies. It's not hard to find if you kind of Google some of them. That gives you an idea of what your overall cardiovascular risk factor is. You can kind of enter information about your family, about yourself, enter some lipid levels, and it will spit out some numbers. Useful information. Of course, nothing's 100%, but it is useful. Regardless of that, it's important to eat a heart-healthy diet, and that includes fruits, vegetables, legumes, beans and things of that nature, nuts, fish, seafood, chicken, and really limit sugary drinks. That I can't emphasize enough. Sugar gets the carbohydrates in them gets converted essentially to fat in your body. So many people don't, I love Red Vine's licorice. I can't get enough of it. But you look at the package, it says no fat. It's true, but it's full of carbohydrates. Those carbohydrates get immediately converted to fat in your body once you're over your metabolic needs. And so indeed, yeah, there's no fat, but it's going to be fat. You want to exercise approximately 150 minutes per week at moderate intensity. Eliminate tobacco and alcohol. Alcohol, just like I gave you my example of the carbohydrates that are present in licorice but not fat. Alcohol doesn't have a ton of doesn't have a ton of carbohydrates necessarily, but it gets the triglycerides on it. Sorry, it raises the triglycerides in your body, and that contributes to belly fat. You want to manage your weight. So again, normal BMI is less than 25, and manage any conditions. So once conditions arise, should they arise, high blood pressure, high cholesterol, things of that nature, particularly if you've used your reputable online calculator and have found that you're at an elevated risk. Well, let's say you do that and you have an elevated risk. You really want to make sure your conditions are perfect. You can't maybe get rid of your conditions, but if you have high cholesterol, you want to make sure that whatever your doctor states, let's say your LDL has to be under 100 or something of that nature, you want it under 100. Because you may not be able to lower your risk, but you certainly can control and manage your conditions that relate to it. Diet important foods include oily fish, sardines, tuna, and salmon. These all contain omega-3 fatty acids. This particular type of fat decreases bad forms of lipids, so you want to eat it at least once a week, and that's something that I try to do whatever I tell my patients. I try to have salmon once a week. Some vegetable oils, such as corn, soy, and canola, and olive oils, are something you'd want to use. The fiber and fruits and vegetables is great for you, and it offers a lot of protection against cardiovascular disease, as do whole grains. Because the whole grains in many cereals and whole grain cereals linked to reduced LDL, which lowers your cardiovascular risk. Eating nuts, I'm always conflicted a bit with nuts. Nuts, interestingly, have a decent amount of calories, and I'm not a nutritionist, but from a calorie perspective, they're not necessarily the greatest thing ever, but they're really good source of plant proteins and fiber and healthy fats, and can lower cardiovascular risk. So I'm always conflicted, because if I'm trying to lose weight, having the nuts can potentially be a source of a significant amount of calories. So I would definitely want to mix those in with activity and exercise. Some special items you may have heard of. So tea, there's some antioxidant properties of tea, green tea, many of you have heard of. They have some effects on blood clotting and blood vessel dilation. Garlic, many have heard of the tortoises that have been, the turtles that have been lived forever, getting garlic and so forth. Lowering, it's been known to lower your total and LDL cholesterol in the blood. Vitamin E is a good antioxidant. It helps to protect against LDL. You can find those in avocados, green vegetables, vegetable oils, and whole grain products. Things to avoid. So we talk about this. Most people know this, but it is worth going over. Limiting fried, fast food, and processed foods. That's just critical. It is a main source of cardiovascular disease in the US and is very preventable. Reduce the intake of refined sources of carbohydrates with higher glycemic indices. Basically, these are high carbohydrate type foods. French fries and that kind of thing. Limit unprocessed red meats, such as beef, pork, and you want to avoid processed meats such as sausages, ham, and salami. Really not good from a cardiovascular perspective, and also from a cancer perspective. There's a lot of particularly smoked things in that nature. So trim all visible fat from meat, then remove skin from poultry. Have no more than 2 standard drinks on any one day. That means alcoholic drinks. A high alcohol intake increases blood pressure, and as I touched on, can increase triglycerides in the blood. Just going back, I think one observation is we see, I think a lot of what contributes, for example, in a climate like Michigan, being from California, it's a challenging environment, and there tends to be more obesity than in warmer weather climates. And I think a lot of that has to do with the combination of being able to get out in the winter in terms of activity. And I don't know whether there's more alcohol consumption in colder states than in warmer states. There probably isn't, but the combination of the triglycerides from alcohol when people are indoors, because there's not a whole lot else to do outside, is problematic. So making a concerted effort to get out and exercise and do things in cold weather is challenging, but it's really important. So one of the areas I want to talk about is peripheral artery disease. I'm going to touch on this, and we're going to kind of go through these at a decent clip. We're going to have question and answer at the end, and I'm happy to address as many as we can. But I did want to talk about specific conditions because some of you may be here specifically for that. So PAD happens when the arteries we talked about in the legs narrow, reducing or cut off blood flow, and is a leading cause of non-trauma related amputations when not diagnosed and treated early. 1 in 20 adults over 50 have PAD. And actually, as you get to over 65, it gets to like 1 in 10 or something. So if you're in that age group, you know somebody or you have this condition, more likely than not. Signs and symptoms that can easily go unrecognized or can be dismissed. I do this for a living. I see it every day, the various ways that these things are missed or kind of find me in a very circuitous way. Leg pain that occurs when walking and stops with rest is one of the first symptoms of PAD. Again, I don't want you to think I had leg pain yesterday, and when I got up because I had been playing basketball over the weekend. I don't think I had PAD, but again, if you have these symptoms unexplained for other reasons for a period of time, something to consider. One foot may feel colder than the other. One foot or leg may become pale, discolored, or blue. Toenails and leg hair may stop growing, and there may be numbness or tingling in the legs that's sort of unexplained. And as I said before, sores or wounds that may heal slowly, they may not heal, or they may heal and they may come back. So just some numbers, just something worth seeing. I know this is kind of very granular detailed stuff, but the take-home message from this slide is we have one study that can diagnose PAD. That's what this slide means, and it's called an ABI. Doesn't, I'm not going to go into details of it, but basically a number of 0.9 and above is normal. As that number goes down from 0.9 down to under the 0.5 or 0.4 range, it becomes severe. So that's really what this is. And it's a really, really good test. The ABI test is as good as many tests that we order in medicine for other conditions. And it immediately gives a diagnosis of it. And it also can give you a prognosis. If your ABI is, for example, under 0.5, 0.4, you have a significant rate of risk of amputation. So risk factors for critical limb ischemia. Sorry. I think I lost what was on there, but essentially smoking is the biggest risk factor. Diabetes is a big risk factor as well. Those are kind of the main ones, but certainly high blood pressure and genetics and so forth. I apologize that got deleted off there. PAD or peripheral arterial disease is a spectrum of disease that ranges from those who don't have a decrease in that ABI number I talked about, to those who develop fatigue and heaviness in the muscles that don't require a lot of circulation at rest, but as you increase your exercise, the demand of the muscles goes up and the supply isn't there, so you get pain in the legs. And that's called claudication. That's the middle part of the slide there. That's not a limb-threatening condition. You can live with claudication forever. You might not be very happy about it, and you might not be able to walk with your grandkids in the mall like you'd want to, but it's not limb-threatening. In cases where it gets severe up to the right part of the screen, when you get pain in the areas furthest from the heart, such as in the feet, or have poor wound healing, so-called ulcers or tissue loss, then it becomes a limb-threatening condition and something has to be done to prevent imminent amputation. So it's really a spectrum of disease. Important take-home messages: asymptomatic or those who have no symptoms but peripheral arterial disease almost never require intervention. To reiterate, somebody who comes to the office has an ABI measurement of 0.7. I told you 0.9 was normal. So they get 0.7, no symptoms, fine. Walk the mall, loving life, traveling all over the world. Nothing needs to be done for them. It would be wrong to do something. Claudication is the central one we talked about, which is involving the muscles, the big muscles in the leg. Always symptomatic. Nobody has claudication without symptoms. It's always exertional, it's always reproducible, and it's not life or limb threatening. Critical limb ischemia, to reiterate, involves pain in the foot. That's the areas furthest from the heart, loss of tissue such as ulcers, always involves the foot, always threatens the limb, always with pre-existing arterial disease in the case of critical limb ischemia. There are conditions that can be acute, but for the purposes of this, that's correct. In terms of intervention, there's non-invasive treatments available. So first is optimization of medical conditions. Everything I said already still applies. You got to, less French fries, less salami, more fish if you're diagnosed with any of these conditions. Tobacco cessation had to happen yesterday. If you're still smoking and you have this condition, tobacco will only make it worse, and anything we do to fix it will fail sooner. Exercise program, so walking either in a supervised exercise program at a clinic or physical therapy department to where somebody's watching you in kind of like a coach situation, or on your own, walking to the point at which you get pain in the legs is fine. You want to build collaterals, those are alternative vessels in your leg to encourage those your leg to kind of grow new vessels, and that's a great thing to do. There's medications. So what kind of medications? There's a medication which most vascular specialists would fully admit is not perfect. It's elastisol or Platol. Helps to dilate blood vessel, inhibit platelets. It can increase walking distance about 50%. We do prescribe those as a conservative measure before doing anything invasive. Aspirin inhibits platelets, makes them less sticky. Platelets are the things in the body that when you cut yourself, they're the first kind of line of defense to help form a clot while the clotting factors kind of get in gear. Plavix is another platelet inhibitor that kind of is a little bit stronger. Those are different, by the way, while I'm on this topic, than quote unquote blood thinners. Warfarin or Coumadin, Xarelto, Eliquis, those are blood thinners. Those work on the coagulating proteins. Aspirin and Plavix work on the platelets, which are a cell. So when people say, "Oh yeah, I'm on a blood thinner, I'm on aspirin," technically not really on a blood thinner. You're on a platelet inhibitor, and so that is an important distinction. Then there's invasive interventions. So if you look at your screen left, there's a blockage of an artery to the leg. This is an example of a patient that I opened up on the screen right. You can see the black signifies the blood. And so you can see that there's an area where there's basically not a tube there. And then over here on the screen right, you can see that it's in line. So that was with a stent, which can be very successful, as in this case. Or also you can do bypass surgery, much more involved. We take a vein out of the leg and we flip it around to plug it in above the blockage and then below the blockage. It's basic plumbing here, but it's done on the body, and it's very small, kind of meticulous suturing, sewing blood vessels together, and that's when blockages are far more extensive. I should take the slide off because it looks like there's a huge fine if because I borrowed this from somebody. There, it's gone. Carotid disease. The arteries in the neck provide the blood supply to the brain, the internal carotid arteries, for example. A very common cause of blockages in my world. Here's an example of a left internal carotid artery. The common carotid artery at the bottom of the screen splits off to a branch to the face called the external carotid artery. Hoping you can see my mouse. And then the internal carotid artery right here, you can see that real narrow. So in this case, the white is the blood flow. It's just a little string there. That's what's left in the blood vessel. This is an extremely common location for blockages to develop in the neck. So how do you know if you have this? Well, who should be tested? Well, your doctor. Many doctors listen to the neck with a stethoscope, and there's something called a bruit. A bruit is a fancy name for just turbulent flow. I don't know if you've ever heard your air conditioner or something making funny noises. That's what that kind of sounds like. It's an abnormal flow. Sometimes it suggests that you've got a blockage in your neck. Sometimes it doesn't mean anything. But it might be a reason to get an ultrasound to look for this condition. People that pass out, it is widespread. You pass out, you get an ultrasound of your carotids. The truth is, it really shouldn't be happening because passing out almost never has anything to do with the carotids. We still do it, and that's a whole other talk, my feelings on spending money on certain tests. Now, however, people who have a history of TIA, which is a mini stroke, or a stroke should absolutely have the carotids checked because the carotids are a very common cause of stroke. And so what is a TIA? It's a stroke that lasts typically short period of time. If you have weakness on one side of your body or temporary blindness, that could be the result of a TIA. If it's permanent, those symptoms lasting longer than a day or so, then that would be a stroke. Then you should have the carotids evaluated. People who are over age 65 with certain comorbidities, so heart disease, coronary disease, other forms of vascular disease, like we just talked about in the legs, let's say still smoking, high cholesterol, those may be reasons to actually do some screening to look for a blockage in the carotids, because there's reason to believe that there might be a higher risk for that. But many, if not most, carotid narrowings are found incidentally, which means in the course of looking for something else. So if we find these blockages, well, who do we treat? Well, if you come to, let's see, my main hospital, St. Mary's, and you have a stroke or a TIA, and we find a narrowing of your carotid artery that's about 50%, based on a number of studies, which could be a 3-hour talk, we'll distill it down to the fact that if it's over 50%, we will treat that. If you have not had a stroke or a TIA, we would treat the carotid arteries at a narrowing of greater than 70%. The threshold is going to be higher because it hasn't caused any symptoms, and obviously the risk-benefit would be leaning towards not doing something because nothing bad has happened. The primary goal when treating carotid disease is prevention of stroke. That's the bottom line. People often ask, am I going to, the usual joke, am I going to play the piano after you fix it? Obviously, if you didn't before, is it going to make me sharper, less dementia, less any of these things? No, it is purely to prevent stroke. This is an example of surgery performed on the carotid artery, which we do very frequently, where we open the artery up, we put a shunt in the artery to redirect the blood flow to the brain during the procedure, and then we remove the plaque, and then we close it up afterwards. That's one way, and the most common way since the 1950s, that you can clean out the carotid arteries. The other way of doing it certainly involves stenting. Many of you are aware that stents are a common thing, and we do that. And there's actually a third way, which is kind of a combination of surgery and stenting that's been around that, again, I don't have time to go into, but suffice it to say, these are very effective ways of treating. And the last area I want to touch on is abdominal aortic aneurysm. The aorta, which I mentioned at the beginning of this talk, is that central blood vessel in the middle of your body. It's the so-called water main. And in some individuals, men actually about 4 times more than women, there can develop degeneration, or this pipe can actually break down and form a balloon called an aneurysm. Typically, these are the kidneys right there below the kidney arteries, and there you could see an aneurysm form. And that, risk factors for aortic aneurysm disease include smoking. I don't know if you've got kind of where I'm going with this, older age and family history. Smoking is an incredibly potent contributor to the formation of aneurysms and the growth of aneurysms. It's almost a direct link in this particular disease process. How would you know if you have one? Usually you don't. And it's usually discovered incidentally. In the most common patient I see who has one went to the emergency room for a possible kidney stone. They get a CAT scan and they find a kidney stone, but they also find an aneurysm, or on other studies. It's highly lethal if left undetected. What does that mean? Well, they can burst and rupture and die from that. The lethality is less than it used to be, but there's still at least a 30% chance of dying if they rupture. And so early detection is really the key. The SAVE Act, which I can never remember, it is something about I can't remember what it stands for, the acronym, but it was signed into law by George Bush around 2006. And basically, anybody who's over the age of 65 who enters Medicare at that time is entitled to with a history of smoking, is entitled to an ultrasound study of their aorta one time. If you're over the age of 55 with a family history, it'd be recommended at that point in time. So rather than finding it from your kidney stone, you can get this for free under Medicare, certainly at the age of 65, but the recommendation would be at 55 if you have a family history. So when to treat aortic aneurysms? The size of the normal aorta generally is around 2 centimeters at the abdominal location. Over 5.5 centimeters in males based on very good studies is when we treat them. Females, far less females have them, as I mentioned, 4 times less. The data is not as good. Most of the studies, I'll spare you the details. It studied aortic aneurysms, did not contain a lot of women. These were VA studies and just the disease that's not as common in women. But generally, women have smaller aortas, so we treat them at 5 centimeters or greater. If there's rapid growth of the aneurysm, we would treat it then. And then there's unusual circumstances where we may treat it at a smaller diameter, which again is a little much for this conversation. What is the most common way of treating it? Historically, the way aortic aneurysms were treated was the belly is a major surgery. The belly is open. The aorta is on the spine, actually, so you have to go through everything to get to that location. And we still do this. We do one next week. We're doing one next week, but it's under, kind of extraordinary circumstances where there's no other technology that would allow us to treat it. And what is that technology? Stenting. These days, we're able to use stents that we can place inside of the aorta to divert the flow into the stent rather than the aneurysm. And so the aneurysm is still there, but it basically shrinks down and no longer receives blood. And so this technology is truly amazing. It's been around since around 1994, and it is our primary go-to treatment for aortic aneurysm disease. It's like a one night in the hospital thing. So some things that I wish everyone knew. This is just sort of a list of things that kind of I encounter throughout the day. Understanding, by the way, not everyone can know everything about anything, but if you're talking to a vascular specialist, which is what I do, things that I wish people kind of knew. So maybe takeaways a little bit from here. Arteries are not veins. They have very different roles in the body, and the arteries are really critical in delivering the important nutrients. And blockages in arteries are a big problem. Blockages in veins can be DVT and clots, but generally are not life or limb threatening. Smoking is the cause of most peripheral vascular disease. Antiplatelet drugs are still important, but they're not are still important. There was some studies that were a study that was out in the past year that got kind of covered in the New York Times, and that made aspirin seem like it's not something people should be taking. But the real point of the study was that in general, aspirin is maybe not something widespread healthy people should always be taking. But if you have vascular disease and are being treated for that, generally speaking, it's still good to be on antiplatelet agents. But of course, that's between what your doctor prescribes for you, so consult them. But they're not blood thinners. Most peripheral blockages need not be treated or even looked for, which gets me to my next point. What about vascular screening, ultrasounds? That's a big topic. In general, you probably see these fairs or hospitals advertised to have screening. I'm not here to poo-poo that in general. But there is a very mixed benefit to doing screening, to just showing up and getting your aorta looked at and that kind of thing. Absolutely, there's stories where lives are saved, diseases are caught, and everything is great. But there's also a questionable benefit in people of normal risk who go in to have these studies performed, which may or may not find diseases, which when treating them may or may not necessarily improve quality of life or prevent death. What about, and vascular surgeons treat vascular disease using all available tools, and surgery is only part of our story. And I just want to plug for that. There's a lot of good specialists who are in our space, but it's really all we do in vascular surgery is treat vascular disease and have a long-term relationships with patients and do both surgery and the interventional work. So we're sort of agnostic to the types of treatments. With that, I believe that's my last slide. Thank you. And I think we're going to turn this over to questions next. I think Brittany's helping me with that.
Yes, thank you so much, Dr. Greenberg. As a reminder, if you have any questions, you can use the little Q&A speech bubbles down near the bottom of your screen. And Dr. Greenberg, I will tee up these questions for you to answer. We did actually receive quite a few questions prior to your presentation. So a few of them you may have already covered. If you could just reiterate those answers again, that would be wonderful.
Yeah.
For someone who has vascular disease, is there a specific exercise that you would recommend that they pursue?
I think it kind of depends on the actual location of the vascular disease, to be honest. But I think in general, walking and low impact walking kind of thing. And if you're able to do even more, but vascular disease tends to be a disease that afflicts people of a little bit of an older age. And so doing, jogging or running may be a lot to ask and may be hard on the joints and bones. But I would say that walking to the point at which you get pain and then resting and then starting again would be what I would recommend.
Thank you very much. The next question is, do iron infusions or other infusions affect vascular health?
I can't go into specific details about any benefits of iron infusion specifically. I mean, iron is very important in terms of oxygen delivery and in red cells, and certainly oxygen delivery is important, but I can't speak to any particular studies that show that there's a long-term benefit that I know of.
Thank you. Next question is, how does barometric pressure and vibrations affect coronary microvascular disease?
I don't treat coronary arteries, so I couldn't, because I'm not a cardiologist, I couldn't answer that, unfortunately.
Well, thank you very much. Next one is, and I think you covered this a couple of times, what is the number one thing someone can do to improve their risk for vascular disease?
Yeah, I think you're getting at the smoking piece, probably. Smoking is the biggest thing, but exercise, eating a healthy diet, and basically keeping a healthy weight. Those are just huge things. I know they're all cliche, but there's no perfect, there's no other easy way to do it.
Thank you. This one is a little bit more specific, and I apologize if I do not pronounce any of these words quite correctly. There is a trace of regurgitation in my mitral valve. What does that mean? Should I be alarmed? My tricuspid valve has mild regurgitation. I'm just watching and not being treated. I feel fine.
Yeah. I'm not a cardiologist. Those are hard issues, unfortunately. So I can't speak to those.
Okay, thank you. Someone is asking about, what about diet soda? What are your thoughts about vitamins and supplements?
What was the first thing? Diet soda?
Diet soda was the first part of that question.
Diet soda, like anything in moderation. Of course, you're going to expect a physician to say anything in moderation. I think that I'm a big fan of diet sodas. In general, of course, water and even flavored water and those sorts of things are, the closest thing to what we have in our body. There's controversy as to whether or not if you have diet soda, for example, is it going to make you want sugary foods and carbohydrates more? I think the jury's out on that. But yeah, diet sodas is a great trade-off to regular soda, which really does not do anything good other than build fat. The second part of the question was what?
What are your thoughts about vitamins and supplements?
Yeah, vitamins and supplements are good. Again, I'm kind of pretty westernized as far as my training and practice in terms of supplements and stuff. And I don't deny that there's a lot of benefits, I'm sure, to a lot of this supplements. I can only speak to sort of the main trials and those things as far as the long-term benefits. I think there's some benefit to them, but they're not as tried and true as some of the other things we talked about. But certainly vitamin E, vitamin C, a lot of there is benefit to those elements.
Thank you. Is smoking cannabis as risky as tobacco?
No, I mean, as many people know, a lot of the products that are within, for example, cigarettes and so forth, the byproducts, I'm speaking of tobacco, are really some of the more dangerous components. Nicotine itself as a vasoconstrictor has a lot of effects on the body that are unhealthy. And so we're very much opposed to nicotine in all forms, chewing it, inhaling it, whatever. But smoking nicotine-containing cigarettes, it's a lot of those byproducts. Cannabis does not have the same deleterious effects on the cardiovascular system by any means that I'm aware of as nicotine, but I would be wary a little bit about potentially some of the smoked byproducts that are released. So, that's all I can kind of say about that.
Thank you. Next one is, this person has a 35% risk of vascular disease. Is that a normal risk?
No, I mean, I think that would be that's an elevated, that would most definitely be an elevated risk and something that I would want to reduce aggressively.
Next one is it normal for the veins in your leg to hurt when you run your fingers along them or rest a heel on them?
Is it the veins in your legs?
Yes, the veins in your leg to hurt. Yes.
Yeah, generally the veins in your legs should not hurt. So if the veins in your legs specifically hurt when they're being brushed against or touched, that could be a sign of venous insufficiency, varicose veins, and that sort of thing, and could be a cause of vein disease itself. Again, that's different than artery disease. That's vein disease, but certainly that is a treatable condition that could be evaluated further by a vascular specialist.
Next question is, are coronary calcium scores a worthwhile screening?
Again, I'm not a cardiologist, so I can't speak to that. And I would be careful with that. I would just say, it's something that I think coronary calcium is something that cardiologists look at closely. And to my knowledge, there's utility to that. But I would certainly speak with your primary care doctor and or cardiologist about that.
Thank you. The next one, and I think you may have already answered part of this question, but are there any supplements that would help prevent? I know many say aspirin, but is there any other?
Well, I think aspirin's more of a medication than a supplement. There's folate, there are vitamin E, and like I said before, even vitamin C, and there's a number of vitamins and minerals that are beneficial to the cardiovascular system. Prevent is a challenging word. It's as though it makes something that's going to occur not occur. But I think that it can be involved in a portfolio of lowering your overall risk, primarily in terms of primary prevention, meaning if you haven't gotten vascular disease yet, or if you do have vascular disease.
Could you touch on the hereditary effects of vascular health?
Yeah, that's a good question. That probably would be a 5-hour talk to touch on it. But generally, there is a strong hereditary component. Some of it we know and can put our finger on. For example, lipid conditions where people inherit conditions where they're more prone to high lipids. These are well worked out genetic abnormalities. And that can be, people can have tremendously high lipids and as a result have heart attacks at the age of 20. When clearly that's stronger than any cigarette, right? Amount of smoking you can do. So there are definitely hereditary components as clearly defined as lipid genetics or other ones that we haven't yet defined and scientists are working on trying to figure out what they are. But there's a strong hereditary component. I'm always cautious about that when talking to families, particularly since we're still in the fallout of the rampant smoking of the 1920s through 1990s plus. It's hard to separate sometimes hereditary from from environment, right? Which is the secondhand smoke. When they say my dad had this condition and he died young, well, how much did he smoke? Well, they smoked a lot, right? So it's hard to sometimes sort that out.
Thank you. Would you be able to share any information on non-ruptured thoracic aortic aneurysm?
Sure, yeah. So thoracic aortic aneurysms are aneurysms that we did not touch on. These involve the aorta that's above the diaphragm that is slightly larger. So generally speaking, there's also an association with smoking in those aneurysms. They're less common. And because the aorta size is larger than the abdominal aortic size, we increase the threshold typically. So we recommend fixing those when they're about 6 centimeters as opposed to 5.5 centimeters in the belly. Only other thing I would say is they're far more lethal. When those rupture, they're invariably fatal. Sorry to be so morbid, but that's just how it is.
Thank you. Can you speak to renal arteries and how they can be monitored?
Yeah, another good question. So renal arteries are involved in obviously they go to the kidneys. When narrowings form in them, much like patient like I saw today, when both the kidney arteries get involved with narrowings, it can produce significantly elevated blood pressures that can be refractory or in the presence of multiple blood pressure medications, they may not be effective and complications from that can arise, such as headaches from high blood pressure, heart failure, need for hospitalizations as a result of that, and so forth. So treating that sometimes can get rid of that risk. Very controversial area. We have gone away generally from treating kidney arteries in all but the most severe circumstances. And I would really, anybody who's listening who is contemplating having their kidney artery fixed, would really push the person who wants to do it, for example, as to why exactly it's being done and what has failed that in terms of medications or what more can be done medically. Because really, there's not a great reason to do it these days, but in very, very rare circumstances to treat the kidney arteries, but in very rare circumstances. As far as following them, I think that was part of the question. Generally speaking, there's not a whole lot of reason to continue to follow the kidney arteries. The decision to treat them is not based on the amount of narrowing, it's based on the clinical situation, the blood pressure and things of that nature.
Thank you. Next question is, can edema in my legs be a possible vascular issue?
Yeah, another good question. Much of my day is many patients I see is for the diagnosis of edema. We get blamed a lot for edema in vascular disease. The reality is a lot of edema, if not most, is not vascular, is caused by other things related to maybe a mild heart issue, a mild kidney issue, liver issue. There's a number of things that can contribute to it, but there are causes of edema that are vascular in nature, such as venous disease, and a vascular specialist could help evaluate that. So yes, long-winded answer, but the answer is it could be vascular disease, certainly could be investigated once the other areas have been kind of looked at.
Thank you. Next question is, are there any known correlations with stress and vascular health?
Stress?
Yes.
What was the first part? Any
known correlation?
Yes, lots of it. In all areas, stress increases inflammation, which inflammation is not good at all for the heart. It's not good for the blood vessels, which can create and make blockages worse. The reality is it's like anything in life. There's a happy medium. I don't think there's anybody here right now that goes through life without any stress. If you do, please maybe tell us how that happens. But the reality is too much stress can contribute to vascular disease. Yeah, yes.
Thank you. The next question is, what should someone do if they are concerned about their vascular health based on some of the signs and symptoms that you reviewed?
That's a good question. I would say the first thing is reach out to your primary care physician and however you get a hold of them, particularly and the speed of which may be dictated by how severe the symptoms are and how typical they appeared to match what we described this evening. And I would let them know. obviously these are the symptoms that we just in terms of walking and things like that. Any severe symptoms of that nature after hours, you should, be seen by emergency room, but yeah.
Thank you. Another question that was emailed over, and I think you may have mentioned something regarding this, is are there screenings available for those who are at high risk that you would recommend?
Those who are high risk, I would say that if you're high risk, generally speaking, you would have probably been identified as high risk by your cardiologist or by your primary care doctor, and I would ask them to initiate, screening of your circulation, and they should know, based on what we talked about this evening. If that doesn't get you far enough, there are screening programs at local hospitals that do testing. And so that would be one avenue to go, to keep your eye out for those screening programs when they come. It's not just hospitals, some churches and schools do this testing with some frequency, but generally I would hope that this would be something that would be done by your primary care physician or cardiologist.
Thank you very much. And I have one more question. I am unsure if this is in your area of expertise. It does say, is there anything I can do to manage my vascular necrosis?
Avascular necrosis?
Yes,
Yeah, that's different. That's a different condition. That's an orthopedic condition.
thank you. Well, that wraps up all of the questions that we received both via our chat and over email. So thank you so much for taking the time to answer all of those. And thank you to everyone who has joined us for this evening. We appreciate you being here, and thank you to Dr. Greenberg for a wonderful presentation. We hope you will join us for future Wednesday Wellness topics.
Thank you. Have a good night, everyone.